This video is all about drugs for angina. What is angina? It's marked by a very severe chest and back pain, or a tightness in or a pain in the chest. And the reason it happens is to do with the fact that the blood has its own blood supply, just like any other tissue in the body, and as such it needs oxygen and nutrition just like any other tissue. So when blood leaves the aorta, of course most of it goes to the rest of the body, but a small proportion enters the left and right coronary arteries, and these then supply the heart muscle with the required oxygen and of course nutrients, but oxygen is the main thing that's a problem in the short term. So angina happens when the blood supply to the heart is not enough for the heart's oxygen requirements. In other words, oxygen supply becomes less than the oxygen demand. And this isn't anything unusual. Any muscle will, if you contract any muscle in the absence or when there's not enough oxygen, that will result in pain. And that's the same during exercise. That's what causes the pain of exercise. So angina happens then when the blood supply to the heart is not enough for the heart's metabolic needs. There are three types of angina: stable angina, unstable angina, and variant angina. Stable angina is when you get pain predictably occurring during exercise or exertion. So this happens when normally if you're at rest there is no pain, but then when you start to run up the stairs or to run for a bus, you start to get pain in the chest. That's stable angina. Unstable angina is when pain occurs during less and less exercise or exertion. So whereas before running up the stairs would cause pain, now you're finding that simply walking up the stairs or walking on a level surface starts to bring about pain. And eventually the pain actually happens even when you're at rest. So this is unstable angina. These are the two most common ones, and of course they're just two things on a spectrum. There's another one called variant angina, which is quite rare, and you get this when you get pain at rest, but it's caused by a spasm of the coronary artery. So in other words, this artery here contracts spuriously, so it starts going into spasms, and that causes obviously a lack of blood supply to the heart. So how are these things prevented and treated? Stable angina is prevented by statins, which reduce atherosclerosis and help to preserve the quality of the blood supply to the heart, and aspirin, which prevents small blood clots. It's treated by a combination of nitrates, beta antagonists, and calcium blockers, or by simply, well, sorry, not or, but what all these are doing is actually reducing the amount of work that the heart is actually doing. So nitrates widen the arteries, so do beta antagonists, and so do calcium blockers. Unstable angina is also prevented by statins and aspirin, but in addition is also prevented by clopidogrel, which is an ATP receptor antagonist. The treatment for unstable angina is the same as stable angina. Variant angina is treated, again, the same way. So you basically got these three ways of treating reducing work: nitrates, beta antagonists, or calcium blockers. So let's have a look at those three ways of treating angina. We can block beta receptors, we can try to reduce calcium entry into the heart muscle, or we can add nitric oxide. Let's see what each of those do. So let's look at blocking beta receptors first of all. You'll remember that the heart is controlled by both the sympathetic and the parasympathetic autonomic nervous system. The sympathetic nervous system serves to increase the force and the rate of the way the heart contracts. It also increases the automaticity. Automaticity is the tendency of heart muscle to contract automatically. So you can think of the sympathetic nervous system as being part of the fight or flight type of responses. So that helps to explain these effects up here. The parasympathetic nervous system, which is the rest and digest branch of the autonomic nervous system, decreases the rate. It doesn't affect the force, but it does also decrease automaticity. The heart receives input from both the sympathetic nervous system and the parasympathetic nervous system. If we focus on the sympathetic nervous system, remember that there are beta receptors on the heart which respond to the release of adrenaline, and that increases the contractility of the heart. You can see this experimentally. Here's a control situation before you add any drugs. You can measure the tension in the heart muscle, and you can also measure the level of intracellular calcium. In the presence of isoprenaline, which is a beta agonist, so it's mimicking adrenaline, when we add isoprenaline, we get a much stronger contraction and a considerably bigger rise in intracellular calcium. So we want to stop this from happening, because if the heart's demand for oxygen is higher than the supply of oxygen, then you can decrease the demand by getting the heart to work less. So, given that adrenaline makes the heart work more, we want to